And hi, Harvey. It's
Hey,
lovely to have you as part of this conference. And you've been telling me about this notion of personhood and how we can provide dignity to people by recognizing their personhood. Can you tell me a little bit about why that's important and how you think we can encourage that or ensure that people are recognized for their personhood?
great. Thank you for that. So I suppose the lead up is, I mean, I've been doing palliative care research for nearly 35 years and have looked at a whole variety of issues that affect end of life experience for patients and families. Um, at some point, I mean, after I had kind of looked at some of the more traditional issues in terms of, the psychiatric domains like depression and anxiety and suicidality, I began to realize that there were more things that were affecting people as they approached the end of their days that weren't kind of in the traditional psychiatric realm, and discovered that if you look at the Benelux countries where euthanasia and assisted suicide is being practiced for certainly a good long time before the advent of Carter versus Canada here at home, the reason the data suggested that people were seeking out an end to their life was lost sense of dignity. Up until then, there was really no empirical data on the notion of dignity at end of life. Dignity was just kind of used kind of as the ultimate ace that you would play in supporting whatever contentious position you held. So if you felt that euthanasia and assisted suicide was a way of supporting your autonomy, a way of saying, this is my body, my life, then you would say, this is fundamentally a dignity issue. And on the opposite side of the political fence, if you felt that this was a violation of the Hippocratic Oath, that the taking of life was inconsistent with kind of core tenets of medicine, you'd say this is fundamentally a dignity issue. We decided, I mean, we were not kind of the moral police. We wanted to approach this as empiricists, as researchers. So we began doing studies on dignity and looking at how patients understood dignity, what some of the correlates of dignity were, and developed many innovations over the years that were part of that body of research. Then we discovered that one of the most fundamental issues that seems to be in play regarding whether or not dignity is upheld or undermined has to do with this notion of how people experience themselves to be seen or appreciated. Metaphorically, and I wrote this in an article called Dignity in the Eye of the Beholder, in which I talk about the fact that although this is data driven, I mean, we did mathematical modeling to predict, what is the most ardent predictor of sense of dignity and depression, anxiety, all kinds of measures. This notion of appearance or how we felt we appeared to others was the most ardent predictor of dignity. And so the article Dignity in the Eye of the Beholder essentially says metaphorically, what people are looking for in the eye of the healthcare provider is a reflection that will affirm their sense of personhood, their
Mm.
sense of self. In other words, nobody wants to be seen exclusively as being the embodiment of, their ailment or their condition, at the exclusion of being seen as a whole person or this notion of personhood. So, with that being said, we also discovered in other studies that we did that this notion of no longer feeling like the person I once
Mhm.
was a very profound existential question for people who were facing, various different physical challenges, healthcare challenges, um, which again speaks to this notion of, am I still me? Do people appreciate me not just in terms of what I have or the condition that I am labeled with, but in terms of the human being, the whole person? And although, I mean, we give lots of lip service to the idea of the importance of person-centered care, you can't do person-centered care in the absence of knowing who is that person.
Right.
You can do other things. You can give polite care. You can give even perhaps attentive care, but you can't do person-centered care in the absence of knowing who is this person. So we, over the last number of years, have been playing with an idea. Well, more than playing with the idea, we've actually developed this idea into research protocols that are now being replicated in other centers around the world. And the idea centers on a very brief question. It's a probe, so it's meant to elicit a conversation about personhood. And the question is what we call the PDQ, or the patient dignity question, which reads, what should I know about you as a person to take the best care of you possible? How do you study such a thing? Well, the protocol, the way it's operationalized, is we go to the bedside of this individual, and we'll say something to the effect. And this isn't, an exact script, but in essence, we say we know a lot about you medically. We know a lot about, the condition, the ailment that brings you here. But we also understand, and I've never quite said it to someone like this, but we also understand that no one likes to be seen as kind of a differential diagnosis or a problem checklist. So what we're here to talk about today is, who are you as a person? And so we ask the PDQ, so what should we know about you as a person to take the best care of you possible? And that then is meant to elicit a conversation anywhere from 5 minutes to 15 minutes that is focused on personhood. So who are you? What matters? What are your values? What are the things that are critical? What are your responsibilities? What is it that you're worried about in terms of self? We then go off and we summarize this into 2 to 3 paragraphs. We come back to the bedside for 3 reasons. We read it. We allow the patient to make any editorial changes if there's something that doesn't quite represent self accurately. And then the litmus test. Do we have your consent to place this on your medical chart? Because the idea is, of course, if this is how you want to be seen, then here's your chance to provide us with the lens that everyone is meant to put on when they walk in your room, so that they don't just see your condition or your ailment or whatever malady has brought you to a medical attention. They see you. And the way they see you is shaped by the way you have kind of shaped that lens through the PDQ. At the end of that, we then do some evaluation, have done evaluations with patients and with family members who in some instances have done this by proxy, or with healthcare providers who then go on and read the PDQ. And with the patients, in the first study we did, there was about a combination of 125 patients and families. Invariably, they all gave consent to have this on the chart. Everybody says, this needs to be on the chart. And not only that, they say, and every person in this circumstance should be given the opportunity to put personhood on the clinical radar in this way. We also ask them other things in terms of their feelings about this, and they say, this is something that healthcare providers should know. It could affect my care, and I want it out there. I want it known. When we ask healthcare providers how they respond to it, in 90% of instances, they say, I learned something that I didn't know about this person before. And again, these are all people that working in palliative care. So they're, even though there could be ceiling effects, in spite of that, 45 to 65% of them say, it enhanced my sense of respect, connectedness, empathy. And also, there was increased satisfaction reported, job satisfaction reported by healthcare providers who availed themselves of the patient dignity question. We also did a PDQ study in intensive care during COVID, and we called family members at home, and it was extraordinary. I mean, to have family members, and I may have shared this with you in an earlier conversation, Yuta, where we spoke to, on one occasion, I remember speaking to a young woman whose mother was on a ventilator, and this was a First Nations woman, and the daughter basically talked about wanting to find a way of impressing on the healthcare staff that her mother was no ordinary person. And she went on to say a few things about her mother, who had really been kind of a spiritual guide in her community, and summarized her response at the end by saying, I'm so happy that this PDQ has given me a way to help others see who this person is that they're looking after. There's also been much larger studies than I was able to conduct, a study of several thousand patients at Memorial Sloan Kettering with end-stage cancer. Again, finding that this is a way of putting personhood on the radar and a way for people to be able to identify, what a patient's goals of care might be, through the lens of personhood. So why did I want to bring this to you into this meeting? Well, it seems to me that many of us who enter into healthcare, depending on our circumstances, struggle to varying degrees to have personhood known. Now, if you are able to speak, if you happen to be articulate, if your anxiety is suppressed or controlled enough that you can make sure that you are seen, then it's not necessarily as challenging. But what if you are dealing with somebody whose gaze is tainted by, elements of ableism? Who's making assumptions based on what they are seeing, and therefore jumping to the conclusions of who you are. Could we find a way of using at least the kernel of the idea, the PDQ, as a way of giving patients an opportunity, even preemptively, to say, this is me? And so could we somehow create a platform, and whether it is based on an iPhone or whether it is web-based, in which patients can be given the PDQ, patients can be given cues that can elicit specific domains that they might want to address. So at the end of the day, they have a brief summary that says, whoever else you see, whatever else you see when I walk into the emergency room, see me,
Mhm.
see me. Which in some ways, if I think about, I think last time I had just suggested some names that we might use for such an entity, but see me is not a bad one.
Right.
People want to be seen. And so I hope that what we might be able to do then is to be able to develop some kind of a technology solution or platform that perhaps might be used if we were to look at a specific population. And again, it seems to me that this is something that everybody at some point might want to avail themselves of, because at some point we don't necessarily have our voice. But could we begin with a group of individuals that find themselves oftentimes being challenged in terms of personhood, being seen, the being seen through a lens and distortions that ableism imposes, which is why I thought, what about the disability community in Canada? Might this be a group of individuals who would see this as an opportunity to make sure that whatever happens in healthcare encounters, that patienthood doesn't eclipse personhood? So that is my that is my pitch. Um, that is what I'm hoping that we can kind of discuss and see if we can take it several steps further and eventually perhaps find a way that we can implement it.
That's great. I love the that patienthood doesn't eclipse personhood. That's a wonderful way to summarize that. And
Hmm,
it'll be great to discuss this with you at the during the workshop that we're holding in May. So thank you so much for this summary. That was perfect. Um,
excellent. Well, I'm excited to be given the opportunity, and I'm really looking forward to the discussion and where we might take this.
Great.